Swayam Prabha. Digital India. Educated India.
Hello one and all. Today we'll try to delve into a topic that's very relevant, at least where India is concerned. Before we get into the nitty-gritties of the topic, let us first look at a case scenario to acquaint ourselves well with this topic. A 56-year-old man, he has presented to the OPD with a history of an ulcer which is non-healing in nature over the bottom of his foot, a trophic ulcer if you will. Now this ulcer is around 2 centimeters in width and it is lying over the metatarsal head. Additionally, he also on examination has reduced sensations to pinprick. The lab test showed a mild derangement in the creatinine function which is around 2.9. Now this is almost twice the level of the upper limit of normal. That means it is increased and we are dealing with possibly some of the renal disorders. Now which of the following tests would you think, which are given below as your options, would be most possible to be found in this patient? Now you may have hypoalbuminemia, that's your option A, or is it glucosuria, which is your option B, or is it C, which is hypokalemia, or D, which is leukopenia. Now if you use your head for this, you'll realize that somewhere we are in the parlance talking about concepts of sugar. Maybe, maybe not, given the history that the patient has paresthesia as a non-healing ulcer. Certainly in the context of our milieu of Indian society, we think of diabetes. Wouldn't it be true? Possible. So if you're thinking glucosuria, you're along the right lane. The others may or may not be present in the same patient, but at the point of discussion, you have glucosuria. Now, we'll be talking about diabetes mellitus across next 1 hour or so, and we'll lean towards these objectives to understand the tissue better. You have glucose homeostasis. Now, that becomes very fundamental to understand what goes really wrong in diabetes mellitus. We'll try to discuss some recent criteria for diagnosis. Who should be labeled as a diabetic? Who is a pre-diabetic? That's a very burning question. We'll try to address them. We'll also discuss the classification of diabetes mellitus. Now we know, we used to call it type 1, type 2, insulin dependent, insulin not dependent. Now that's a very redundant concept. There are more things that are evolved which target etiology. So we'll try to look at that as well. We'll also try to understand what inherently happens in these two entities, that is your type 1 and type 2 diabetes. What is the pathogenesis which underlies these disorders? We look at some of the organs which show telltale features of diabetes in them. And also we'll discuss some of the complications which is quite, I would say, prevalent given the nature of diabetes and the course of the disease. We'll try to understand those complications as well. Now if you look at the definition, it's quite a simplistic definition. It's a group of metabolic disorders, they say, which share a very common feature. So the common denominator there is hyperglycemia. Now you'll see also that chronic hyperglycemia seems to be the fundamental problem here, because not only does it portend metabolic derangement, but also has the potential to damage multiple organ systems. If you look at literature, there are quite a few references which will tell you that India is the diabetes capital of the world, given the number of pre-diabetics and also diagnosed diabetics, the prevalence, old and new cases of course. And because it is so intricately linked with sedentary disorders such as obesity or lifestyle disorders, the word diabesity epidemic has been almost used synonymously with this condition, certainly where India is concerned. Now that's quite the trivia to swallow. Inherently we know that it has to do with the glucose metabolism. In physiology you would have learnt a lot of detail about glucose metabolism, but what happens that is so radically different that your glucose derangement causes hyperglycemia and that portends such a vast array of problems? The answer, if you look at it, may be underlying in the homeostasis in itself. So a good understanding of glucose homeostasis will give us a better idea to understand the derangements in diabetes. Now if you take food, we know that we'll consume a meal, a very sumptuous meal, and you expect within a half an hour or so, your plasma glucose level starts to spike. It increases, maybe more than 200 milligrams per deciliter. But immediately your body mechanisms come to play. The check and balances. What happens to the glucose as it percolates through the plasma, reaches different organs? Particularly in the context of the pancreas, it reaches your islet cells of Langerhans. The beta cells which are there, imagine this glucose, okay, the schematic representation is that of a beta cell. As the glucose reaches somewhere along the tip of the beta cell, we know that there is a receptor inviting to join it. That receptor is GLUT2. And a GLUT2 internalizes this glucose moiety, and this glucose reaches the cytoplasm. Now we know this glucose will be immediately used by the body to produce energy or ATP. So this ATP generation begins at the level of the cytosol. One of the byproducts, tangentially if you will, of ATP generation is it causes some amount of change in your potassium channel, which gets inactivated. Now we know that once your potassium channel is inactivated, it causes membrane depolarization. This membrane depolarization has almost a downstream effect over your calcium channels, which open up. And opening up of calcium channels is a floodgate where the calcium from the plasma influxes into the cytoplasm, and once it gains entry through the gradient, this causes some conformational change in your granules within the cytoplasm. Now these granules in your beta cells we know are storehouses of insulin. The insulin is in the pre-pro form, some of them is in the pro-insulin form. All these zymogens get converted to active insulin, and as we know, this active insulin, they will be secreted out. They are ductless, of course, so directly into the bloodstream, the endocrine part of it, and they'll be released into the bloodstream as insulin. Now as your plasma insulin level increases, what we call as insulinemia, it has downstream effects further. Of course, it will act upon your skeletal muscles. The skeletal muscles, it enables it to increase the protein synthesis and glycogen synthesis in the muscle. A minor part of it also acts upon the adipose tissue or fat cells in the body. Because it is such an anabolic in function, it increases lipogenesis, so it enhances the fat deposition and also increases glycogen synthesis. So the glucose levels start to brought down in your plasma. It also reduces some amount of lipolysis. The major organ, however, tends to be the liver. In the liver, it has similar change in the sense that increases the lipogenesis, and it also increases the glycogen storage or synthesis in the liver. At the same time, new glucose formation is also inhibited. Net effect of all of this, I would tell you, is the level of plasma glucose is brought down or tempered or regulated. Now, how do you diagnose a patient as diabetic? Somebody comes to you to your OPD or your dispensary as an intern or possibly as one of the branches of medicine that you undertake. Diabetic patients do tend to turn up. So what do? How do you call a person diabetic? Remember, these are entirely based upon your blood tests. You would want to do a basic panel of blood tests before rendering the patient as a diabetic or a pre-diabetic. On the screen is the current WHO bar ADA, that's your American Diabetic Association criteria. If you look at it, you look at FPS, which is your fasting blood sugar. If you do a fasting blood sugar over 8 hours of fasting overnight, come to the lab and deposit your blood early in the morning. Now, if your blood levels is somewhere less than 100 milligram per deciliter, you're quite safe. Now, if it's somewhere between 100 and 125 milligrams per deciliter, you may want to run the test back again because you may be labeled as a pre-diabetic, meaning the overt symptoms of diabetes are not there, but you're predisposed, and maybe in a few years' time, you get to be put into the category of being a diabetic. Of course, at the far end of your screen, you can see if your levels of your fasting blood sugar is more than 126 milligram per deciliter, you will be called as a diabetic. Same goes with postprandial blood sugar or PPBS. Usually this is after the consumption of a meal, or more objectively, if you take more than 75 grams of glucose orally and then you do your charting of your test every half an hour. Now let's say if your levels are less than 140 milligram per deciliter, you're normal. If it's more than 200 milligram per deciliter, you will be termed as a diabetic. Some of the other anecdotal criteria that they use is random blood sugar. You randomly walk into a lab, give your blood. If it is high, are you a diabetic? Possibly. If your levels are more than 200 milligram per deciliter on 2 or more occasions, and you have some classical signs and symptoms such as polyuria, polydipsia and polyphagia, we'll address all of those entities later, you may be called as a diabetic. Or better yet, now you have HbA1c, which is your glycated hemoglobin, which will give you an idea about your glucose control across the last 120 days in the life cycle of an RBC. Now, if the level tends to be in an increment or the wrong side of 6.5%, there's a good chance they'll call you a diabetic. Now, let us go into the classification of diabetes. Now, this is important because from years and years, we understand it as IDDM, NIDDM, type 1, type 2. Now, that's a very simplistic concept, one would say, because also an old concept which is on its way out, because now we know the new classification that's been put forward by WHO and ADA is quite exhaustive and quite functional, in the sense that it targets your etiology rather than merely the signs and symptoms, which is very important because you want to eradicate the disease at the root. Type 1 diabetes, which is a complete annihilation of beta cells, so they are destroyed completely, and you get what is called as an absolute insulin deficiency, so no insulin at all. Now, they tend to be generally an immune mediated response, almost like an autoimmune disease. If you remember your autoimmune disease classes under immune disorders, diabetes also was discussed under those terms. Sometimes you do not know the cause, it comes under the bracket of what is called as idiopathic diseases. In contrast, however, you have your type 2 diabetes mellitus, where the sentinel events which are under type 2 are either insulin resistance or there is a complete beta cell dysfunction or a combination of both. We will discuss all these entities in little later in the ensuing slides. Now, if you look at your type 2 diabetes mellitus, you can further break them down into so many of them. Inherent defects, genetic defects of beta cell function, such as MODY, maturity onset diabetes of the young. You have any of these nuclear factors, transcriptional factors which are defective because of some genetic mutation. As they are seen on the screen, you have MODY1 to MODY5 based upon what is defective. You also have neonatal diabetes, a recently discovered entity in the last decade or so, where there are mutations specifically in ABCC8 and KJNJ11. You also have maternally inherited diabetes and deafness, MIDD, where there are certain DNA in the mitochondria are mutated, or you may also have problems in insulin which is derived from proinsulin, so the conversion of proinsulin is defective, or you may have inherent problems in gene mutations in insulin in itself. What about some of the other things on insulin action? It is synthesized, but its action is not effective. There are certain genetic mutations such as type A insulin resistance, lipoatrophic diabetes, problems of the pancreas in the exocrine segment such as chronic fibrosis or pancreatitis, any tumor, trauma, pancreas being resected for whatever reason, cystic fibrosis, hemochromatosis. All these disorders essentially destroy the microenvironment of your pancreas. So, certainly your islet cells will take a hit there. Or you may have problems such as endocrinopathies. We know that diabetes essentially is an endocrinopathy, and they are intrinsically linked to other disorders like Cushing's, acromegaly, hyperthyroidism, so on and so forth. Okay, they may be associated with certain tumors such as a pheochromocytoma or even a glucagonoma. Infections, very important because they can augur in type 1 diabetes or even type 2 diabetes in most extents, such as a viral infection caused by cytomegalovirus, Coxsackie B viruses, and rubella. Congenital rubella are most known of the lot. To finish the list, you have some other disorders like drugs. Of course, we are in the era of pharmacotherapeutics and pharmacology, right? So, you have steroids, thyroid hormones, interferons, protease inhibitors. All these drugs, there's a litany of them. I've just selected few of them. These are all can be implicated in secondary type of diabetes, okay, what's called as type 2. Some of the genetic syndromic associations such as Downs, Klinefelter, Turner, Prader-Willi are associated with diabetes. And of course, what we have not mentioned so far is what is called as gestational diabetes mellitus. In your postings in OBG, you will definitely come across this condition where the onset of hyperglycemia starts somewhere in the early or the late first and second trimester and tends to increase across the trimester, and suddenly post delivery the sugars will be normalized. So, it is in that time frame that it is captured and it's called as gestational diabetes mellitus. More on that entity maybe sometime later, but try to remember this entity as well. Now, let us look at type 1 diabetes mellitus. Type 1 diabetes mellitus almost behaves like I told you as an autoimmune condition, where your effector cells of your immune modulating cells will attack your beta cell antigens. The net results, as we understand, is complete destruction of the beta cells. So, absolutely there is no insulin there, and this is a disease which you tend to see around puberty. When the child is in the school and they will complain of weakness and weight loss, and on blood tests generally diagnosed as diabetic. So, starts at around puberty. Earlier terminology called as IDDM, insulin dependent diabetes mellitus, holds true because these patients are absolutely, they require injectable insulin. If you look at hark back to the pathogenesis of type 1 diabetes, we'll try to understand it because it's never an isolated entity. All diseases generally are a combination of factors. So, you have what is called as autoimmune diseases, which it is, then of course the person has to be genetically predisposed. So they'll have certain HLA signatures which make them more vulnerable to develop diabetes mellitus type 1. Also, a trigger such as an environmental factor is also present. So we'll discuss these entities under them. So you can look at genetic predisposition, inheritance of certain HLA molecules, okay, on chromosome number 6 if you remember, such as DR3 and DR4. They have a very high chance of developing diabetes mellitus. So they have localized it to these particular alleles, maybe DQ8 even, okay. So they have a higher propensity to develop diabetes mellitus compared to, let's say, a regular population. Other non-HLA genes are also responsible for the same, maybe outside the scope of discussion for the race class, but certainly implicated as well. Now we have environmental insult commonly with, let's say, cytomegalovirus. We'll take that context. Now these viruses will bear certain antigens which have very striking resemblance, as epitopically speaking, with that of the beta cells. So as the viruses are being attacked by immune cells, your T cells, both CD4 and CD8, will also attack your beta cells, what is called as molecular mimicry, if you remember from chapter in immunity. Now this will cause damage to the beta cells, which will bring about a lot of damage in your islets. So there will be an immune response generated against normal beta cells and or altered beta cells. Net effect is this autoimmune attack will completely deplete your stores of beta cell destruction, resulting in lack of insulin and of course chronic hyperglycemia called as type 1 diabetes mellitus. So this is almost like a template example of autoimmune disease. Now if you look at the natural course of the disease of type 1 diabetes mellitus, the person of course is genetically predisposed, like I told you, HLA and non-HLA allele inheritance, and around about 10 years to 15 years is where you tend to see them, around puberty and so on and so forth. As you can see, the graph is depreciating quite steeply, because you'll see the overt immunological abnormality maybe around 10 years. 15 to 20, you will see more a progressive course of the disease where the glucose level hovers around normal, sometimes dipping low and high, but around 20 is where you tend to see them stabilize as hyperglycemia and label them as diabetics. That's the natural course of type 1 diabetes. Type 2 in contrast has certain signatures such as an autoimmune disease is almost ruled out. You tend to have an overplay of genetic and environmental factors, but underlying them is what is called as a very important state called as pro-inflammatory environment. They also are insulin dependent. Earlier they were called as non-insulin dependent diabetes mellitus. Now we know that oral drugs, hypoglycemic drugs, may not be effective and they have to resort to insulin injections. Now here the principal problems in type 2 diabetes mellitus, the template prototype is generally an obese person somewhere in the mid 40s or older and generally tend to be affected. They tend to have specific areas, for example, more than obesity hovered around buttocks and the skin, or visceral obesity in their abdominal fat. They tend to have more tendency to develop type 2 diabetes mellitus, and certainly they are more pathological, meaning to have more complications. Sedentary lifestyle is an important independent risk factor outside of obesity. And if you look at the pathogenesis of the same, you have two issues as we have spoken earlier about it: insulin resistance and beta cell dysfunction. Now insulin resistance is where you have a failure of your target cells to respond normally to insulin. For example, your skeletal muscles. Now when the insulin will be released after a meal in your plasma, that insulin causes internalization of the glucose and uses it up. Okay, that may be in the fat, also sometimes in the liver as discussed earlier, but sometimes it so happens that there is failure to inhibit gluconeogenesis within the liver because of insulin resistance. Now we know that leads to a high FBS levels, fasting blood sugar. That's why it's more than 126 milligrams and you'll be called a diabetic. Sometimes there are failure of glucose uptake and glycogen synthesis within the muscles, generally tend to go in favor of high postprandial blood sugar levels. And of course, there's added insult of failure to inhibit lipoprotein lipase, which is an enzyme, remember, responsible for conversion of triglycerides. So there will be increased amount of free fatty acids, which adds insult to injury. These are seen typically in insulin resistance. Obesity in the context of insulin resistance in itself, we know that central and peripheral. Central generally tends to be more. Body mass index is a directly linked parameter. Increase in the body mass index, you have a higher chance of developing type 2 diabetes. Free fatty acids, more the number of free fatty acids, we know that it gets converted into an intermediate metabolite, diacetylglycerol, DAG. Now what it does is basically competes with glucose for substrate oxidation. Now, once that happens, your glucose is not utilized and it's very high, so it leads to hyperglycemia. Fat can be stores of hormones and enzymes. For example, they are called as adipokines. Okay, so sometimes there is reduced levels of adiponectin. These also can cause hyperglycemia. And we told about pro-inflammatory stress. So increase in the inflammatory levels will trigger inflammasome pathway within the macrophages, resulting in what is called as a storm of cytokines, which have downstream effect, chiefly resulting in derangement in your glucose metabolism. Another prong of your type 2 diabetes mellitus is beta cell dysfunction. So initially you will see in these patients who are more than 40, we can look at our own families and the friends that we know, above 40s and maybe in the 50s. Initially their glucose levels are what is called as euglycemic levels or near normal. They will hover here and there, but then settle down within a few years. So initially there will be increased function of your beta cells. So it almost overcompensates for the loss of it, resulting in hyperinsulinemia. Over a period of time, this compensatory mechanism is deranged or overwhelmed, resulting in a relative insulin resistance, not absolute but relative. So then also there are other co-contributors like excess free fatty acids, which results in lipotoxicity. You can get chronic hyperglycemia, which is glucotoxicity. Amyloid deposition over a long period of time gets deposited in, let's say, in the muscle or maybe in the kidney. And sometimes there are derangements in the genes involved in insulin secretion in itself. Okay, all these are underlying your beta cell dysfunction. So net effect, as a genetic predisposition and obesity, we know there is peripheral tissue resistance and inadequate utilization of glucose, resulting in insulin resistance. The body tries to overcompensate for this, causing beta cell hyperplasia transiently, which maintains your glucose levels in normal range. Go back a few years time, maybe half a decade or so, you will see that your beta cell failure starts, and those are early figures where you'll say impaired glucose tolerance, and finally it results in late failure where there is absolute annihilation of beta cells, resulting in what is called as type 2 diabetes mellitus. So just to summarize some of the salient differences as we understand between type 1 and type 2. So normally type 1 you will see it in childhood and adolescence as compared to adults in case of type 2. But you will tend to see more of these in childhood as well because of the abnormal food habits. The weight loss, certainly a feature of type 1 compared to type 2, where you tend to see more obesity. Circulating pool of autoantibodies is a feature of type 1 as opposed to type 2, where you don't tend to find them. Insulin levels, absolute lack in type 1, whereas a relative lack and a gradual decline in type 2. Diabetic ketoacidosis and other complications, as we'll approach in the next class or so, generally tend to see more in case of type 1, whereas type 2 you tend to see more of what is called as HHS. Okay, we'll come to what that issue is, hyperglycemic, hyperosmolar situations. Pathogenesis wise, we know that autoimmune conditions, so your T regulatory cells are extremely going rogue and they're destroying your beta cells in the pancreas, as opposed to, let's say, in type 2 where there is beta cell dysfunction and insulin resistance, which we talked about at length, resulting cumulatively in lack of insulin uptake and utilization in the periphery. So these are cornerstones of the diagnosis and pathogenesis of diabetes mellitus. In the next class, we'll delve further into the complications, the pathology of diabetes, which is a very relevant issue as we address it. Thank you for your time.